Okay, so welcome to the show. I'm joined by my guest, Dr. Michael Lovich. He's out in New Jersey, correct?
Actually, no. I'm a little bit all over the place now.
Okay.
I have an office in Boston. I have an office in Denver. I currently live in Denver now.
Okay. Nice. Nice. Well,
Right now, I'm coming from Santa Monica, California, where I'm doing a little bit of a work vacation to
oh,
get all the work, all the business admin stuff done without all the distractions.
yeah, even better. That's great. I'm sure the weather there is pretty perfect right now.
It's nice.
Yeah. So today, Dr. Lovich, you wanted to talk about kind of give an intro to what functional neurology is. We wanted to dive kind of deeper into um, concussion and emerging research and kind of standard of care for that. Is that right?
Right. Yeah, exactly.
Perfect. So, just before we get started, can you let us know how you got started in this field and what makes you so interested in it?
Sure. So the majority of functional neurologists in the world today, they typically start with a chiropractic degree, even though it's evolved to be a multidisciplinary field where any professional health degree can then learn this stuff and be effective with it if they want to dive 2 feet in. So I was in chiropractic school, and when you're in any sort of educational situation, you're in a curriculum, and you're learning from people who have experience. Um, and I was sort of confused because we were learning all of this science and we were learning all of this knowledge, and then when it comes down to what you actually do for the patient, you get like 7 options to pick from. You can either you can stretch it, you can strengthen it, you can adjust it, you can mobilize it, and so on like that. And it all comes down to the same thing and some pattern therein of that. And I was looking at this, like there has to be a way to tie all this stuff in together. So I ended up doing a master's in sports medicine on top of that. And in that master's, we filled in more of the gaps and tried to put together a little more whole or systematic way to view. And then I was interested in my neuroscience classes. So we had neuroanatomy and neurophysiology, and they both came very easily to me. And I was sitting in my neuroanatomy lab. We had the brain in our hand, and we were going through all the pathways and the tracks. And I was just working there afterwards. And the professor, he actually just retired, but he was coming to help out. He was saying like, this is what this does and this is what that does. And I was like, okay, well, if this is the area that's for negative emotions, this is the area for positive emotions, is there a way to just focus and just hit that area and get that to work more? And he said, well, there's people who think they can do that. You can tell there's a little bit of a backstory there that I didn't think it would be wise to get into.
Yeah.
But his name was Dr. Gillette, I believe. And so I was like, all right, thank you. And we kept like learning about all the cool parts of the brain.
Mm-hmm.
And I found a group of people that thought that they were able to activate specific areas of the brain. And I found a guy local to my school at University of Western States in Portland, Oregon, Glenn Zielinski.
Okay.
Found him on the website. He's local. He teaches for the Carrick Institute. He's got a clinic 20 minutes down the road, and he takes my insurance. So I was like, all right, well, I was diagnosed with ADHD when I was 5 and been on medication. And I was like, all right, supposedly this works with that. I'll go in as a patient. It works. It worked for me. But the fun part was I was sitting on the table. He did his examination and he looks at me. And I don't know if you've ever met Glenn Zielinski, but he's got a look that you can't like recreate. And he looks at me, he's like, dude, have you ever had a concussion? And I was like, no, I don't think so. I've never played like really aggressive sports or anything like that. I've skied, but I've never really had any bad falls or bad injuries. And it was like he knew something I didn't know, just from like he knew more about me than I knew about me. And it was weird. And then I started thinking about it. I was diagnosed with ADHD when I was 5. I fell off a slide on one of those playgrounds in Brooklyn, New York, when I was about 4.5. So, and I was medicated by 5.5. So you start thinking about, could all this ADHD that I have just be a form of post-concussion syndrome? We started working with the brain rehab. He put me through the testing and we did everything there, and all my grades started jumping up and everything started just getting easier for me. Like, just life itself was getting easier because my brain was working better. So I was like, there's no way I can't not learn this stuff. So I jumped 2 feet in, and I don't regret it. I think it's the best idea I've made since in a long time.
Awesome. And obviously Dr. Zielinski is a functional neurologist.
Yeah,
so,
he's located out in Lake Oswego, Oregon.
Uh-huh. And so you decided to follow in that path and start to practice in that manner?
Yeah, he's got a cool clinic where he works at a level above most other chiropractors I've ever seen.
Yeah.
So when you see patients of that, let's call it sensitivity coming in, or that complexity coming in, it's not guess and check and see if it works, or I'm a chiropractor so I adjust. It's how can we get good data, and how can we get good ideas based off that good data, and how can we do the most appropriate therapy based off of the observations that we're seeing and the understanding of what those observations mean.
Great. So you go down this path. For those who aren't aware, we've had other functional neurologists on the podcast, but can you kind of break down exactly what it is and why it's different?
So this is how I explain functional neurology.
Mm-hmm.
I think it's worked out pretty well in communicating it to other practitioners and to the public. Functional neurology starts off with the same neuro exam that you get from any neurologist. And we're talking about a bedside neuro exam, mm-hmm. because that's the same thing you learn in medical school and chiropractic school, your cranial nerve exam, coordination station gait exam, peripheral nerve exam, and so on and so forth. We do the same exam. However, we're not just looking to see if it's working or not working. Because while we do want to know if it's within normal limits or outside of normal limits, we would like to know how well is it working. Because when you're dealing with these vague neurological conditions, and if you want a list of those vague ones, just look at the SCAT-5, the subjective symptom questionnaire, and that's how many people have headache, dizziness, don't feel right, fatigue, trouble sleeping, irritability, anxiety, depression, and so on and so forth, that stuff. So if you are working with all these cases, then they may be normal. And usually by the time they get to our office, or in our office, we're usually like Dr. 19 or 20, they've seen everybody and everybody's done appropriate testing. Everybody's done what is the correct thing to do, except that they're just not looking for within normal, how well is it working? So if one area of the brain or one circuit with the brain is firing too high and another circuit is just firing too low, then the accumulation of all the pluses and minuses associated with the entire part, all the different parts of the brain that we're measuring during examination, then could be creating symptomatic phenomena. It could be creating symptoms even though everything that you test is normal. And when you start looking at some medication or some high-use supplements like St. John's wort and that stuff, a lot of them are neuroactive, trying to work with the neurotransmitter system, because it's just, hey, we know if we give them this, they get this result. So we're just going after symptoms at that point. But then the question is, what if we can find some objective findings or physiological findings that can give us a direction to go in without having to guess based on what you're telling me, this is what you need to do. And this is something that I explain to patients very delicately because it's not something people want to hear. So let's think of it like this. So you have your brain.
Yeah.
And you have all the sensory information from around your body. So you have your visual system that maps out the world around you. Mm-hmm. You have your inner ear that maps out you in relation to gravity, so you know which way's up. and you have your proprioceptive system that maps you in the world in relation to everything else. All of those systems, and we haven't talked about all of them, but the rest of them as well, they all go into the brain. The brain then figures out what it means. It interprets those systems. So you need to have good data coming in. You need to be appropriately able to interpret it. And then as an output, you're going to have a motor output and you're going to have a psychological output. Because when you think a thought, it's always in response to another thought, right?
Yeah.
When you move, there's always has to be some sort of plan to that movement, or else it's pathological usually, right? Like a movement disorder. So when we're working and we're systematically working through the brain and figuring out what parts of the brain need to be rehabilitated, first we have to make sure that the brain's getting good data to begin with. So what does that mean though, from a patient's perspective? It may mean that what you're feeling may not be an accurate description of what's going on in your brain. And I say that delicately because I don't want this to sound like you're crazy. That has nothing to do with this. This is not this is psychosomatic. This is your perception of the world around you is skewed right now. So we need to find a way to reintegrate that information so it's more appropriate.
Yeah.
It's not the easiest thing for people to grasp,
right.
But once you recognize that, then some people actually find great relief from understanding that, because then they say, oh, okay, so all this like weirdness that I feel like my brain is just weird right now, it might not actually be me. It might be I'm just not reading the world right. It's like reading the room, and then they have an awkward encounter.
Yeah. And tell them it's all in your head, but actually it is all in your head. It's all in your brain.
Yeah. It's all in your brain, not in your head.
Yeah. But yeah, exactly. And then if we're not able to interpret, like you said, the world around us, we're not going to be able to process that information appropriately and then respond with motor outputs, whether that be, like you said, a movement or a thought, an emotion, etc. So it's
exactly.
our jobs to figure out where along the line the issues being caused, and yeah.
And another thing, and this is just my little fun with poking the bear.
Yeah.
But the idea of the root cause, there's probably not one singular root cause.
Very true, yeah.
It's probably the interplay of a lot of different systems. And you need to be able to go to somebody, and you need to be able to work with somebody or a practitioner who is able to understand that it's not one thing. There's not going to be one root cause that's going to fix your issue, like removing gluten or doing this one magic exercise or taking this one supplement that's going to stabilize your brain. We have to respect the brain and the human body for the complexity that it is. And instead of spending all this time trying to figure out how do we simplify it to a single treatment, or how do we simplify it to a single modality or a single approach, we have to respect it and say it's complicated. It's probably going to take a lot of different avenues of approach, but we need to have a systematic way to get through it in a certain order that just makes sense physiologically, that makes sense with the science that's available to us to learn from.
Right. And you had mentioned earlier about the in-depth bedside exam that you and the other doctors that you've been associated with perform. What are some other steps you take in that systematic approach to kind of figure out, a patient?
So we do a good history too.
Yeah.
So the evaluation, the intake paperwork that we give is about 45 minutes to an hour. It takes about that long to do, and we give it out ahead of time. And we tell people, throw as much detail in as possible. For some people, this might be the first time that they've actually typed out all of their symptoms, which is nice because now they have a digital record of it. They can save it. And I usually tell people, save it in a document somewhere so you don't have to ever have to retype that ever again. Because some people, they like to write novels.
Yeah.
And I ask for a table of contents sometimes. So the general idea is you have to really talk to the patient. You have to figure out, you can't just say, you know what, I'm this kind of doctor, so I'm going to focus on this thing. And worse, you can't say, this is all you need to do because I'm but in your head, you're like, I'm this kind of doctor. I'm only going to focus on this thing. So I'm going to tell the patient it's the only thing that's necessary. You need to be able to work outside your ego and say, you know what? We have to be able to cross-train. We have to be able to know more. And if we don't know it, we have to know somebody who's good at it so we can refer. So in our office, in our Boston office with Dr. Grafasi, and in Denver office with myself, we always start with our exam. It takes about 90 minutes. And at the end of the exam, we'll know a couple things. We'll know some exercise that we can give as a home exercise program for just to improve the brain from what we saw there. They're very simple, they're very easy, they're very general, so they shouldn't make you worse. But then when people come back in the office, then we'll do more complex exercises that are a little more risky, but a little more fine-tuned because you can't see your own eye movements, right?
Right. Yeah.
The next thing that we tell patients that if we don't think that what we offer is what is needed to get them better, we will help find them the next step and who to see afterwards. Because taking a patient who's dealing with a brain injury, or taking a patient or a family member who's helping them with that and leaving them to their own devices, they're not trained. They don't know what's out there, and they don't know what's sales versus legitimate.
Yeah.
So one thing that we offer is, if somebody brings out something to our attention, we say, sure, ask as many questions as you have. If we don't know what it is, we're going to look it up for you.
Yeah.
Because we like to give our opinion of what it is, a more educated opinion, hopefully. So that way we can say, this might be a good idea because of this and this, or we don't recommend doing that because of this and this. And we'll say, try leading this person, or I've seen this before and this patient has had a good result with it by seeing this type of practitioner doing this type of treatment. Try doing that.
Yeah.
It's all about being the quarterback.
Absolutely. And that's one of the things that we're hoping to accomplish with this podcast is, by providing a platform for doctors like yourself and other practitioners to really come on and explain what they do and, why they might be successful for a certain type of patient. And then the patient can listen to this and, kind of sort through the weeds of what's out there and what they think would be best for them.
Right. And we're always looking for more people. So we have, I know you want to talk about like new ideas in neuroscience, and I got something really cool that we're going to talk about.
Cool.
But we actually just met with somebody who works, and I'm going to give her a little shout out. It's called Stride Denver. And what they do is they work with TBI patients, and they play the quarterback. They're social workers, and they help organize the patient's life so that way they actually have a chance to recover. Or they help coordinate care between all the different practitioners. So we're going to start working with them, and we're really excited to, because that's something that as a practitioner, it's hard for us to manage all the aspects of a patient that needs to be managed, but that's something that they do. So we're going to team with them so that way everything, hopefully patients have an even better experience in their recovery.
That's awesome. That's exactly what is needed, I think. So we wanted to get into a bit about concussion, right? And some new research in that. Let's get into the meat of that.
So concussion is fun. And I'm giving a presentation a couple times coming up, and it's the same presentation. The general idea is there's a lot of misinformation out there about concussion. And there's a lot of, and it depends on where you are reading the information from, that can tell you how good the source is. There was an article that just came out about these people who are wearing these blood restriction collars around their neck to help prevent concussion. And when you let's just think about that for a second. If you throw a collar around your neck that's going to decrease the amount of blood coming from your brain back to your heart, that means at some point it's going to cause a decrease of blood going from your heart back to your brain, right? It's going to have to slow down somewhere. So while it may create more pressure in the brain, which I'm not so sure is a good thing, especially if you're about to take a hit, let's pressurize the veins first. I don't think that's a good idea. But to then put it on somebody and say, this this will prevent concussion without any clinical trials or any research backing it up, that's more dangerous than anything else. And so I follow Chris Zielinski. He's over at the CTE Center at Boston University. And I mean, just follow him on Facebook, and he says some very, very hard truths for people to hear out on his Facebook page. But it's all about, we need to protect people's brains, or people have to understand that it's not a light thing. You can't take your brain lightly. You need that thing to focus and function the rest of your life. So when patients come to us, again, since we usually don't see them as acutely, even though since I do sideline medical for sports events, I do see them when it just happens that first time as well. Typically what you should do is you get a concussion. You should get it evaluated by somebody who's TBI literate. If you go to the ER, that's good. If you have like some weird things going on, you want to make sure you don't have anything worse, anything like a contusion or any sort of bleed or something that life-threatening. You need to get that taken care of. They're probably going to take a CT. They're probably going to do a good evaluation based off of life-threatening information. And then they're going to say, okay, you're fine. Go deal with this. However, it's a good idea to follow up with a neurologist, a medical neurologist, because that's the appropriate way to go. You follow up with the neurologist, you get them as part of the care plan. This should all be within a week of getting the concussion. Now, getting to see a neurologist may take a couple weeks. So while you're working on that, you should also get in my opinion, a functional neurologist, because since functional neurology is it's a compilation of vestibular therapy and occupational therapy when they do the eye movements, and we even do some things related to what SLPs do. The idea is when you go to a hospital-based concussion rehabilitation system, they're going to be throwing a PT, an OT, and an SLP at you, who are going to work in their own worlds and focus on their protocols. And once you go through their protocol, they're either going to say, you're fine now, or they're going to say, you failed treatment. What do you do now? They say, So to see someone like us, we're able to evaluate for that detail, and then we're able to put you on a program that's going to be specific to what you actually need. We try not to do habituation therapy versus corrective therapy. Habituation therapy, especially for vestibular rehab, is the idea that, let's say your eyes move from here to here. Let's say at this point, you're like that. If you do habituation therapy and you just have them move their eyes back and forth over and over, it may work itself out, hopefully. Or what usually happens is this becomes ignored. And now your entire worldview in this area now has a skew. And you have to look at this and you have to say, okay, well, what other system in your brain besides the ocular system moving across may be needing this area to be functioning and interpreted correctly? So it's important to be able to look at things, not just can you move your eyes side to side, but how well can you move them side to side? What are you seeing? Is your eye going too slow and having to catch up? Is your eye moving too fast and has to slow down? Are you doing something we like to call a square wave jerk because it just sort of jumps around that spot? Or any other combination of issues that we're looking for when we evaluate. So where am I going with this? We're talking about the process of how you should do this. So the idea is when you're learning this stuff and you're trying to find somebody who's good, finding a TBI literate doctor who's able to actually evaluate for this stuff is important. And then you can create a healthcare team that's going to help you get back to function. I believe something like 90% of concussions get better within 2 weeks on their own. So we don't recommend throwing a ton of nutritional support at it until at least 2 weeks after, at least 1 week, but 2 weeks is usually where we say. Because of the concussion, what happens in concussion is you have an inflammatory response. And let's think about how that inflammatory response starts. So let's say you have your brain and your brainstem. When you get into a car accident, or when you are in a football hit, or when you have any sort of whiplash going on, the brainstem and the brain is going to have some jostling. where does most of the shear stress, where does most of the stress go?
Yeah, typically right at that brainstem, yeah.
Right. So if the outside, so my favorite is when you go to the CDC heads up, and I wish that they would change this because it leads to a ton of misinformation and pictures in people's minds of what concussion looks like. But if you go to the CDC heads up thing, which every practitioner at the minimum should be certified in, they show a video of the brain inside a skull, and usually they have like a silhouette of a football helmet around it, just, you know, for a little more artistic flair. You show the brain side to side sloshing around. You show the brain going back and forth sloshing around, and it lights up the outside of the brain, the cortical areas, where it contacts the skull. That's not where the injury is happening. That's not where the concussion is. The concussion is deeper inside the brain. The concussion is right over here where everything meets in the middle. So if the brain, let's say, is twisting around, if you are the brain and you're the outside twisting around, it's really just moving like this. But if you are the inside of the brain and it's twisting around, that's when you actually get shear forces. You get stretches. So there's always going to be more stress being put on the deeper structures of the brain than the more peripheral parts of the brain. So now when we think about that, now we think about therapies that people do. So brainstem functions is going to be a lot of regulation of sympathetic and parasympathetic and all your autonomics coming through. It's going to be regulation of some glandular function or organic function. It's also going to be a regulator of motor function coming through, because remember, that cerebral crew, or the front of the top of the midbrain, is where all your motor pathways come through. Yeah. And it's also your reflexes. So when you're a baby laying on your back and you're trying to figure out, like, I have this and this goes to this hand, it's still mine. Those are all reflexes that you now don't think about. Like, it's a thing that your brain mapped out. Like, yes, this continues to be mine as I move it back and forth between my hands. And those are reflexes that can get damaged in a concussion. Other reflexes, like the ability for your eyes to stay on a target when your head is moving around. That's called your translational VOR or your rotational VOR. When you're walking, how does your head stay static in space? No, it bounces up and down, right? Imagine if you perceive that motion with every step, how dizzy and nauseous would you be? Mm-hmm. Yeah. What if you're doing it on a slightly functional level? Like, it's functional, but what if it's a slight enough level that you're perceiving it, but you can't recognize that's what it's coming from?
Yeah, it's pretty disorienting.
So when you're right, exactly. Yeah. So when you're working on this stuff, you're like, okay, are all of these subconscious reflexes intact? And are they accurate? Are they accurate enough to get an appropriate response and not create symptoms? It's funny how sometimes you can get headaches and migraines to go away just by recalibrating, so to speak. I don't like the word resetting because that's been thrown around so much that I feel like it has no meaning. But recalibrating or fine-tuning the accuracy of your VOR, your vestibulo-ocular reflex, by fine-tuning that, now it's more accurate. Now every reflex that's associated with that reflex and builds on that reflex is going to get better data and have a better response coming through.
Yeah.
So let's talk about, so I like to call this brain-body medicine, because you're not dealing with mind-body medicine, which is I think my way towards a better state and I think my way towards a better feeling through meditation or relaxing. And yes, there is research that shows that it has physiological effects. However, how do we know, based on those studies, when you read those studies, it's not saying when you do this, here is the pathway that does it. It says when you do this, we see this result, so they must be correlated. They're all correlation studies. But if you think about it and you say, well, there has to be a line that we can draw. So if we'd like to play connect the dots, we're all basically large kids. So when we like to play connect the dots and we draw the lines connecting it, then we have to say, oh, it goes through this structure. It goes through this structure. This is how we connect from I'm thinking a positive thought to slowing down my sympathetics or speeding up my parasympathetics or improving regulation of it. But what are you training your brain to do? since neuroplasticity is all about if you do it more, then you wire that system more. And if you wire that system more, then it becomes more efficient. You have more protein in that system. You have more action from less stimulus, right? That's the basis of neuroplasticity.
Yeah.
So if you're training yourself in mind-body medicine over and over again, that means that the minute you're not thinking about it, you're going to have all the symptoms come right back. And I don't know about you, but I can't deep belly breathe all day, every day, constantly. I'd probably get lightheaded, even though I had a really strong diaphragm if I did that. And it's hard to stay in that sort of state. And I found a paper recently that I wish I could find again. I'm sure somewhere on my laptop that talks about the negative effects of people who constantly try to force themselves into a positive mindset. So just because it sounds right doesn't mean it is right.
Yeah.
So
do you remember what it said at all?
No, but it was basically saying that they found that people who were in a positive mindset actually had lower scores on their they did a survey based off of like an anxiety depression type thing, like how much depression they had, how much anxiety they had. They found that people who acted with a positive mindset and did like the live, laugh, love stuff more often and more constantly every day and lived by that ended up having higher scores on their anxiety and depression and symptom checklists than people who were just, living life and taking it as it comes.
Interesting.
Just being like, oh, all right.
Yeah.
It's not bad or good. It's just a thing.
Yeah.
So the fun part is that when we're working with patients and we move away from this mind-body medicine, we say, it's good, keep doing it. But while you're doing that, which it probably helps people get through some tough times. But while you're doing that, we're going to work on the brain-body medicine. We're going to get all these reflexes that you need to work on their own to start working again, or at least to work better. And we're going to train your body to build on those reflexes so that way you can have a more optimized brain.
Right.
And in hopes it reduces symptoms. And we've been pretty lucky so far that we've seen some good results in our clinic.
Yeah, that's great. So you had mentioned something a little earlier. I don't want to backtrack too much, but you had mentioned that you do a lot of things sideline, right?
Mm-hmm.
So for those listening, what are some things that you like to look for in the moment of right after the injury? Just things that people should be wary of.
The SCAT5 is a fantastic tool. If you don't have it or you don't know what it is, it's free through the British Journal of Sports Medicine. It came out of the most recent concussion, which I believe is the Berlin conference. It was the 5th concussion consensus statement. You should read that, or anybody listening to this should read that. That is the most up-to-date concussion consensus statement that we have to work off of right now. We look at a subjective symptom. We look at, there's the Glasgow Coma Scale in there, which is when you first find the person if they're knocked out. But a lot of the sports that I work with, or knock on wood, we don't have that here at all, but not on plaster. There's I've worked with USA Sevens rugby at their Las Vegas Invitational Tournament 3 of the last 4 years, where I've worked on rugby players are just large people. It's a cool sport, and when they're playing sevens, which means that they're running at higher speeds, that's when you get some of these concussions, some of these head injuries, because you're getting high speed collision. And when a person comes out with that, you got to make a decision because they want to get in the game. So we have to have the most objective way to look at them, because we can read them subjective symptom checklists, and they can say, oh, I'm fine, 0, 1, 2, whatever. They'll minimize their own thing. And that's where doing that neuro exam is really good. If there's anybody that I'm worried about where I'm like, you know what, you're not a completely normal person right now. Mm-hmm. You're out of breath. You are something like anything and so forth. Like maybe they're out of breath because they just got a concussion. Maybe they're out of breath because they've been playing rugby. Yeah. Or the other sport I work with is ultimate frisbee, where people are sprinting and going anywhere from a jog to a sprint to flying through the air horizontally for an extended period of time. So the idea is, as the acting trainer on the sidelines, I need to have a good idea of, how much risk is this person at? Because if I send somebody back in and they get second impact syndrome, that is bad. That is not something anybody wants to deal with. And luckily, most of the people in the sports that I'm associated with, so I work with Ultimate a lot more than rugby, because I would do that one tournament. But I've been very happy because all the Ultimate players are very, very aware. They're like, you know what, I'm not going to screw up my brain by trying to play again.
Yeah.
So one of the things I'll do is I'll just say, okay, you're going to be sitting here with me hanging out for the next 20 minutes. And I'll be chatting with him, making a lot of dumb jokes, because, spontaneous smile is one of the tests that we look for. Mm-hmm. And so we'll be hanging out, we'll make dad jokes, it's a good time, and then I can see their mental state and see if it's changing. I can see, and we can retest and do the whole neuro exam all over again. And I can see within a 20-minute span if there's been a change. If things get better, I'll think, okay, maybe they're just dehydrated and they're having neurological effects of that. If things stay the same or get worse, I'll be like, you know what, it's better not to risk it. Take a step out. And then we follow up within 2 weeks or in a week or so, because we have it all documented. We say, okay, how you doing now? And then we try to point them to the right person in their area, wherever they're coming from. Because we'll work with teams from either all over the world or all over the country, flying in for a regional tournament or a national tournament or an international tournament. So it's fun. It's a really cool experience. And if you ever have an interest in working sideline, that is where you really see how all this stuff happens, as opposed to when they come into your office a couple of weeks later and you're like, okay, well, you have a concussion, but you don't have you don't have to make that decision right then and there. You don't have to have too much risk on the line in terms of if when I see them next week, what's going on. If you tell them to go back into a game and they get worse, that's on you. And it's also more important than being on you. That's on that person, because we don't want that person getting hurt anymore.
Yeah.
So it's fun. It's a good time.
Absolutely. So I feel like we could talk about this for probably another 5 hours, but unfortunately we were about out of time. So I wanted to give you a chance to give any final closing thoughts for the viewers or the listeners before we sign off.
Yeah, so can we talk about two things?
Yeah, absolutely.
So I still want to get to the new ideas in neuroscience.
Yeah, absolutely.
So when we're looking at the brain, the theory is that the more the brain is firing, or that whole idea of neuroplasticity, means that the more you use something, the more proteins is attributed to that neuron. And the more you use that neuron, the bigger it's going to grow, creating more volume, right? There's some studies that we're excited to be working with a specialist in MRI on this, but we're just dipping our toe in. So it's just an idea. We're not doing it yet, but we're sort of putting together the program and how we think it may be effective. But the idea of using neuroquantitative analysis on MRI. So we can say, we'll do an MRI. It won't be the whole brain, but we'll say, we think we got a vestibular issue going on. And we'll do a neuroquantitative analysis through MRI of the entire vestibular system, from the ear all the way to the brainstem, firing up and firing down. It's pretty cool.
Yeah,
and
awesome.
I'm hoping that maybe in a couple of years that'll turn into an objective marker that we can associate with our bedside neurological exam.
Yeah.
Instead of sending people for an individual test like a SPECT scan or or a DTI, where they say, this is your finding, we have a protocol based on your finding, we can see if it correlates with bedside exam.
Cool.
And that would be so cool, because it just means that we're getting more and more accurate with what we're doing.
Absolutely. And that was great so far. So thank you very much for sharing with us today. I thought this was perfect.
Thanks for having me. This was so much fun.
Yeah, of course. Well, if our listeners or viewers wanted to find out more about you and your clinic or what you're working on, any projects, how would they reach you?
All right, this is a little long. Okay. So you're in the New England area and you have somebody that you want to get evaluated, or you just even have a general question, shoot us an email to boston@deltasperformance.com. If you are in the mountain region and you have a question or anything at all like that, send an email to frontrange@deltasperformance.com. We have those 2 offices so far. The general idea is you don't need to see us for us to talk to you. Just shoot us an email, and if you have a question and it's not too much of a, if it's not like this long thing where it's going to be like an hour or 2 conversation, then I'm happy to just answer questions to make sure you're getting good information back. The last thing I want is for you to go onto like Quora or Reddit and start asking questions and or go on Facebook and start crowdsourcing ideas for what to do with the brain, which is so complicated. Mm-hmm. So that's how you should reach out if you're a patient or a prospective patient. If you're a clinician hearing this stuff and you want to chat or meet, just same emails, shoot us an email, be like, hey, I heard this thing, want to chat. If you're a athletic director, or if you're you play a sport and you want to have us providing the sideline medical services for your event, just info@deltasperformance.com will get you to the right place for that.
Awesome. Well, thank you again very much. I thought this was super informative, and I think a lot of people are going to get a lot out of this. So,
yeah, I hope so.
Yeah.
Thank you.
You're welcome. So this has been your host from the Neuro Wellness Podcast. Be well.